First of all, I would like also to thank the Jena Valve Technology Company, because I think that this is a clearly very interesting topic, and for sure it's not only because the disease itself is tricky, it's also because now we have new hope for these patients with aortic regurgitation, because we have new treatment options. So with this in mind, let us start with when to refer overcoming the bias in aortic regurgitation. And Madalena will cover it.
Thank you very much. Thank you for inviting me to do this talk. It was a pleasure to do something outside the guidelines and the previous talks, actually. No conflict of interest. So, is there bias in aortic regurgitation currently? There is a lot of bias, unfortunately. First of all, there is bias related to the etiology and the associated natural history of aortic regurgitation for each etiology. There is bias regarding the surgical risk, which used to be high, and much of the evidence is actually very long-standing, is from times when the surgical risk was higher and there was no transcatheter intervention. There is bias related to age and to sex. So I'm going to try and cover this. What do I mean by etiology and natural history bias? I mean the fact that most knowledge comes from bicuspid aortic valves. So most common AR cause in the young is bicuspid aortic valves. So the evidence comes from the young with bicuspid aortic valves, and there is well-known good prognosis in these patients, with survival near as good as expected, both for men and for women, and with very slow progression of the aortic valve disease to being severe, and very slow progression to need for need for surgery. And it's also coming from the fact that in the past, so this paper in Jack from 1992 talks about congenital aortic regurgitation, natural history and management. And if you look what they were waiting for a diastolic thrill. So they were waiting for heart failure plus severe aortic regurgitation. They were waiting for left ventricular strain on the electrocardiogram or other evidence of left ventricular dysfunction. So practically, it was a very high risk of surgery in the previous decade. And the fact that the patients were young and compelled to a mechanical aortic valve as the only solution, that was making the medical community wait so long and get used to the ventricle growing bigger and bigger and weaker before offering surgery. So this is a big bias. However, subsequently, even less than a decade later, evidence started to emerge of the fact that severe aortic regurgitation has poor survival without valve intervention. And we have to look a little bit at the survival numbers here. And you can see that if you have if you're symptomatic, you already have almost 10% risk of death. Per year. So that is yearly rate of 10% is a gigantic year if you have symptoms of aortic regurgitation. If these symptoms are class 2, which some studies in valve disease consider class 2 level of symptoms not very symptomatic, you have a risk of 6.3%. However, if you have symptoms class 3 to 4, you have a risk of almost 25%. That means 1 in 4 will die within a year with severe aortic regurgitation and symptoms, which is much worse than aortic stenosis. So we need to focus more on aortic regurgitation because it's a more deadly disease than aortic stenosis. This study subsequently used actually 2D echo long-term follow-up and started to understand that end systolic measures of the left ventricle are signs of dysfunction associated with poor prognosis. So there are other etiologies affecting the young, though. It's not only bicuspid aortic valve, and I already showed this case with cusp prolapse, which is underdiagnosed, and the natural history is not well described. We don't know if it progresses more acutely or whether it takes only several decades, whether aortic regurgitation can be just moderate for several decades and then suddenly become more severe. The natural history is less well known in these patients. Then there is this type of etiology of aortic regurgitation, restriction of the aortic valve because of aortic root dilatation with a central loss of coaptation. So we can see clearly that is a complete central loss of coaptation throughout diastole. So obviously there is holodiastolic flow reversal, so there is severe aortic regurgitation. Now, central loss of coaptation of the aortic valve is perceived as being able to be only caused by dilatation of the aortic root. So if people measure the aortic root to be normal in size, they say, well, I can't call the aortic regurgitation severe. The regurgitant jet is central, the aortic root is not too big, so it cannot be severe. However, I'm going to pass this, which I'm showing how to assess the regurgitation in these patients with dilated, and go back to my point. However, the most common current cause of central loss of coaptation of the leaflets and aortic regurgitation as the population ages, as we all live longer maybe than we should, it's aortic cusp retraction. So because there is some calcification of the aortic valve, which only involves the commissures, it doesn't extend in the cusps to cause aortic stenosis. By the calcium, there is retraction, like scarring of the aortic cusps. It's similar with what happens in the mitral valve when there is mitral annular calcification and leaflets are retracted and there is regurgitation, so the regurgitant mark that we call it. So it's very more and more observed that you can have severe aortic regurgitation in the elderly with mild calcific degeneration at the commissures and central loss of coaptation. And it's not very clear on the transthoracic echo, but I'm going to show you the CT of the same patient, how beautifully you can see some calcium near the commissures and maybe also in this cusp with a central loss of coaptation throughout diastole, so with severe aortic regurgitation in this patient with normal aortic root. So retraction, scarring of the aortic cusp, calcific aortic regurgitation is the pathology of the old. And you can see there the lack of coaptation and a little bit of scarred cusps in this patient with severe aortic regurgitation. You can see, I'm showing this slide again here to show you, to imagine the vena contracta, which will be consistent with the orifice you see. And to see in the next patient a similar vena contracta, a similar hole in the center regurgitant lesion, however with coaptation of the cusp. There is no loss of coaptation. So this aortic regurgitation is only mild, but with the same type of vena contracta, you can have severe in the other patient just because of the length throughout the cardiac cycle, because of the anatomic orifice which causes regurgitation throughout the cardiac cycle of significance. Age and sex bias, which is my last sort of bias for these patients. So most of the evidence naming regurgitant volume higher than 60 milliliters as representing severe aortic regurgitation is male, evidence is male dominated. So the cohorts were male dominated and men are bigger than women and all the volumes can be bigger than in women. We observed that actually, it was observed that actually index dimensions and subsequently index volumes are better predicting long-term survival, probably because they also are less biased towards women and also towards individuals with small body size. So it's better to index. Age bias remains the dominant evidence. You can see that the age of the individuals is actually in the bicuspid age. So they're young individuals. And why do I point at age bias? Because it was demonstrated that low flow in individuals with no other disease and asymptomatic is pretty common with age. So stroke volume less than 35 milliliters per centimeter square is pretty common as we grow older. And it means that the old have a small heart, small stroke volume, small end-systolic volume. So how will you manage in this volume if the entire stroke volume is 57 milliliters? How would you wait for 60 millimeter regurgitant volume to call it severe? It will mean emptying the arteries in diastole, right? So it's not compatible with life. So we shouldn't wait for such thresholds in the elderly, which have smaller hearts. And why do they have smaller hearts? Why do they have stroke volume low? I love this paper from 1988 from Journal of Clinical Investigations, which demonstrated that we lose our ability to adaptate to aortic regurgitation with age. So what they've done is they surgically caused severe aortic regurgitation in young sheep and old sheep, and they saw that initially the end diastolic pressure was raising similarly in both. However, at 4 months, the pressure continued to rise in the elderly because there was no adaptation when the young had adapted to the severe aortic regurgitation and the end diastolic pressure normalized. I think that that's beautiful, and the knowledge was there since 1988, but only more recently we observed clinically that that is the case. I believe that the loss of adaptation to aortic regurgitation and the high prevalence of low flow in the elderly may explain why PVL in TAVI in the elderly has a strong effect. And this was demonstrated on the PARTNER 2 trial that actually paravalvular leak, when it's more than moderate, has a significant effect on the left ventricle. And with a longer follow-up, for this meta-analysis published recently in Structural Heart of 38 studies, even mild PVL in the elderly. So mild aortic regurgitation in an individual of the age that has lost adaptation to aortic regurgitation and has a high prevalence of the low flow has a strong impact. So consider that when you assess. I've already shown this paper about the fact that 38% of patients requiring aortic valve intervention don't currently meet criteria for severe aortic regurgitation, which means that we need to change the criteria. And this beautiful paper from Cleveland Clinic, published recently, has demonstrated that in women and with age, there is less enlargement of the left ventricle. So do not wait for the ventricle to enlarge in women, and do not wait for the ventricle to enlarge in the elderly. So in conclusion, leaflet restriction is a common aortic regurgitation cause in the older patients due to retraction. New cutoffs for severe aortic regurgitation are needed, and new left ventricular volume thresholds are needed for women and over 60 years old. Thank you very much.
Thank you, Marina. Well, we have a great panel of discussions here also. Patricio is here, Maria and Becky is sitting here. And also we have some questions already for you. But let us move to the second talk about Victoria, and then we do the panel discussion. Imaging perspective, beyond the guidelines, Victoria.
Thank you very much, and thank you very much to Gina for having invited me for this symposium, and also with a title that I like very much, because we are used to have the guidelines and to follow them and think that they are right, but actually the best part of the guidelines is to make them, because there are so many discussions about topics that there is still no data clear that gives you a lot of imagination to think about new studies. So starting with the guidelines, this graph has been shown. This is the algorithm that the ESC and EACTS guidelines propose for the treatment or the management of patients with aortic regurgitation, and first is to look for another reason for intervention, which would be the ascending aorta. And probably the survival of these patients improve because we look at the aorta. If there is an indication for the aorta, then we take as well the valve. But otherwise, it becomes a little bit more difficult because we need to quantify well the severity of the aortic regurgitation. We need to integrate the presence of the symptoms, and eventually, if there are no symptoms, we need to check the remodeling of the ventricle and the ejection fraction and the end systolic diameter. And these cutoff values are based on registries quite old that perhaps sum up 900 patients. We have now more data from registries, more contemporary data, and perhaps in the future these cutoff values are going to change. But they are always related to outcomes, and we need to take into account that perhaps the natural history is not there anymore. So the key questions that we have in order to think beyond the guidelines is actually the questions that we have left in the guidelines and that you need to read the gaps in evidence in order to continue doing research in that topic. One is quantification. We have heard very much that we use the cutoff values for echo, but CMR perhaps has different cutoff values. We need to understand how left ventricular remodeling happens. we need to take into account the chronicity of the aortic regurgitation, but depends on when the aortic regurgitation starts and how old you are. As Madalena showed, the ventricle may not respond in the same way, and we can have more symptoms or worse outcome, even though we have less aortic regurgitation. And then we have the type of treatment. Here there is surgery. Will this change in the near future? That we need to see if the new data that we have will change the guidelines. So in terms of quantification of aortic regurgitation, we have this algorithm, which is quite easy, and I like to explain which I think is the way. It's like mild or severe aortic regurgitation. And there you have these different quantitative, semi-quantitative, and structural parameters that help you to decide whether it's mild or severe. Then in between, then is when we have the gray area, which could be moderate, and then we have to do quantitative evaluation whenever is possible. But first, go to those parameters. Think about all the tips and tricks that Madalena has explained, because we can have already a clear idea if it's mild or severe. Mild, you don't have to do anything. Severe, then you need to do something. And then we have the quantitative evaluation, where we have the effective regurgitant orifice area, the regurgitant volume, the regurgitant fraction, and if is beyond 30 millimeters square, 60 mils per beat, and more than 50%, that is severe aortic regurgitation. Then we have the gray zone with the moderate aortic regurgitation, and if it's indeterminate, you can go to transesophageal echocardiography, and preferably 3-dimensional echocardiography or CMR. CMR, we have also plenty of different ways of assessing. Don't think that is the gold standard, that is what we think, but there are also limitations to this technique that we need to be aware. And it's important to see that actually the regurgitant volume that studies based on CMR have put forward to define the severity are lower than those 60 mils. Why? Well, perhaps the population that were included in those studies had also already a stiff ventricle. And they are always checking the cutoff value of regurgitant volume or regurgitant fraction against the occurrence of primary endpoints, which is development of symptoms, decrease in ejection fraction, development of guideline indications for surgery event based on LV dimensions that we know that are old, or death under medical therapy. But is this a definition of severe, or is this a definition of a defect that leads to worse outcome? Because, to be clear, severe could be the same with ECHO, with CMR, or with whatever. That is a regurgitant volume that is considered severe. But what has prognostic impact is different. And there depends very much on which population we include and how these patients are followed, the cutoff values may change. So always take with a pinch of salt all those results and think about what is definition of severe, what is definition of prognostic significant. And there is important to take into account the LV remodeling. We cannot use only the quantification of the regurgitant volume or the regurgitant fraction. You need also to take into account which is the cavity that takes on that volume and how does it manage. And each patient may be different because they have coronary artery disease, because they have older age and they have a stiffer ventricle, because they have maybe an infiltrative disease. So these cutoff values that the guidelines propose to continue observation or to go for surgery may change depending on each patient, and therefore other techniques such as, for example, the assessment of the myocardial fibrosis with cardiac MRI or progressive enlargement of the left ventricle, and therefore we need to use the same imaging modality to evaluate that progression of the left ventricular dilatation is important. Remaining questions that are for me is the same remodeling for the same regurgitant volume or regurgitant fraction. There is where we need more data, how each patient remodels. How is the interaction between LV remodeling and regurgitant volume and regurgitant fraction? It's the same for the various patients, it's the same for men and women. And how does the mechanism of aortic regurgitation influences the LV remodeling? It's not the same, the one that has hypertension than the one that has a rheumatic heart disease. So these are factors that the guidelines cannot take into account because there are no data on that. In terms of the remodeling, this example is similar to what has been shown. It's a 61-year-old patient, no coronary artery disease. He refers symptoms, so therefore has already an indication probably for surgery for this aortic regurgitation, and the ventricle is already 66, and 3 months after aortic valve replacement we see this ventricular function. Should we have to operate earlier in order to prevent this? So this is what the group of Hector Michelena already tried to propose in this publication, plotting the ejection fraction and the end-systolic diameter and systolic volume against outcomes. You can see that the cutoff values that the guidelines propose, perhaps we should go much earlier to 60% of ejection fraction and not to 55, and in terms of end-systolic diameter index, go to 20 and not to 25. Other techniques that can help us to identify the patients at risk, using, for example, global longitudinal strain. There are also retrospective series and prospective series showing the value of global longitudinal strain and the association with outcome. Selecting the patients for intervention based on this, we need more demonstration. And again, the presence of fibrosis as assessed with CMR that has shown that those that have myocardial scar, either if it's infarction type like or not, they have worse outcome than the ones that do not have. Now, in terms of treatment, that was the last one. Currently, guidelines put surgery, but is there any other option for these patients? Actually, they have already used TAVI with devices that are not designed for this pathology in patients who do not have a surgical option, patients that have contraindications. Think about patients with an LVAD. Think about patients that are very old. And the challenge that we have is that many times we don't have the calcification of the valve in order to see it on fluoro, in order to anchor that device. So therefore we need a specific device that is selected for this pathology. And for that, we have, for example, right now data accumulated using the GinaValve trilogy system, which has specific anchors that take on those leaflets and allow much safe and fixed position at the time of the deployment with no leakage. These are the size that we have, from 27 millimeters to 31 millimeters. And the population, for example, the EU real-world data that we have using this system, 58 patients with 36% of them female. And then you can see the size of valves that they have been used. The Euro score is quite high, 6.69, and ejection fraction below 50% is 66% of the patients. The results, technical success in these 58 patients, 100%, in hospital mortality 0, so safe, and at discharge, 90% of them didn't have aortic regurgitation, and this was remained at 30 days of follow-up. So I think that from an imaging perspective, beyond the guidelines, what to think of is try to do a better job in quantifying aortic regurgitation. But again, perhaps using a lower threshold to perform 3D imaging modalities if we are going to use for prognostic purposes. Understanding the interplay between aortic regurgitation, LV remodeling and outcomes, perhaps more deep phenotyping, and we will see the new guidelines that are under development will have will take into account the new data to provide alternatives to patients at high surgical risk with perhaps TAVI dedicated prosthesis. Thank you very much for your attention.
Thank you. Thank you, Victoria. No doubt you hope for treatment in these patients, because also no doubt we need a specific valve for that. So what we are going to do is, I have received many questions. We have the discussions here, don't be shy. So I'm going to start for a question, not for Madalena, because she already commented that, but what is, in your opinion, of the panel, about the proposed dimensions for intervention by sex, by gender, those proposed by in the paper in Jack Akintoye. And the main question is, do you think that the threshold is highest for young men, intermediate for older men, and lowest for women.
Is it on? Yeah, no, I think that there have been a number of studies that have supported the use of different cutoffs by sex, particularly in the CMR literature, and I think that it's very robust the volume differences that one can acquire. Whether or not on echocardiography there are sex differences when you index for body size, I think that indexing, as Madalena had mentioned in the prior sessions, that indexing for body size becomes really important. It's where the 20 to 25 millimeters per meter square may normalize again for the gender differences that we're seeing in these patients. But remember also what Madalena said, and has been shown by multiple studies, that you don't dilate as much. Women don't respond the same to both aortic stenosis, to mitral regurgitation, to aortic regurgitation. And they just don't dilate as much. And so it is possible that we will also need gender-specific index values, which we now have for CMR as well.
Any other comment?
Yeah, maybe you already answered the questions, but there are many issues to better understand. How is the remodeling process? Is there homogeneous remodeling, or is that starting at the apical part, moving to the basal part of the ventricle when it is appearing? Cutoffs are always referring to diameter. We measure the diameter with 2D echo and not M-mode, of course, but volumes are probably better than just diameter. So we still need to have more data. I'm convinced that we need gender differences, for sure. I remember there was also a cutoff of 22 millimeter per met square. So meaning that 2025, that's true. Maybe age will be considered, but not sure that today we can say that there is age difference in the cutoff values that we propose. And at the end of the process, because you talk about imaging modalities, of course, echo, CMR, but don't forget how is treated the patients. Because sometimes we do a technique, but the patients didn't take the beta blockers, but other times on echo he will come today and he have beta blockers. So you don't know how it is, and you have to deal with this information before interpreting the data.
Okay, I have here another question. Aortic regurgitation, post-TAVI. So we have already implanted TAVI. Do you think that the patient who didn't experience aortic regurgitation previously, so it was a pure aortic stenosis, and now develop aortic regurgitation post-TAVI, lower the thresholds?
So, I mean, you already said it in your talk, basically, that the typical TAVR patient has a small and also already hypertrophic ventricle. So they deal quite badly with PVL, even if it's more than mild. So even if it's only moderate, they deal very badly. But I think we do not have any, please correct me, I'm very humbled by all of your presence here to correct me, but I don't think we have quite strong evidence for a PVL or transvalvular regurgitation in post-TAVR patients, right, Becky? So
we looked at it in the partner trial. We could not find any significant difference in mortality depending on whether you had pre-existing AR or not. But a recent meta-analysis has come out that suggests that what we believed would happen, which is that if you have pre-existing AI, you'll tolerate AI a little bit better, is probably true. Having said that, we should all strive to not have PVL.
On the other hand, exactly, if we have the ventricle that has aortic or a part of aortic stenosis before, then we definitely need to make sure that we don't have PVL. And with new systems, we have less rates of PVL after treating them via like the TAVR than with the older systems. So that's a good point then.
Madalena, the gender bias is only in trials or is for the prevalence of the disease in male?
I think the bias in the entire clinical practice is the same, like I said before, about bicuspid aortic valve. They can have severe aortic stenosis with no calcium. But because we're biased, because 99% of patients with aortic stenosis we see have calcific aortic stenosis, we want to see calcium to call it. It's the same with aortic regurgitation. The bias is in in the clinical practice, and because we count on evidence obtained from men and from young men.
Okay, we have here another question for Victoria. Do you think this new proposed thresholds for severity will be in the new guidelines? Do you think?
You can have in the guidelines whatever cutoff value you want to go, but we should go beyond those cutoff values and think about the patient, because the guidelines are there not to make you stop thinking. You know, it's kind of orientation, but each patient is different, and particularly aortic regurgitation, if we think about the mechanism, is so heterogeneous that you cannot put all the patients in the same box. You need to put different, because you have the one that comes with an aortic dilatation and aortopathy, or the one that comes with hypertension that leads to aortopathy and have aortic regurgitation. That patient may be different than the one that comes with a bicuspid aortic valve, for example, or a woman that comes with a congenital abnormality, or the one that develops endocarditis, cures, and then has the aortic regurgitation. How are we going to put all those cutoff values different for each one? We don't know. But of course, the guidelines need to come with kind of simple recommendations to make sure the patients are going to be safe.
Can I just say, I think that this paper from Cleveland Clinic, Akintoye paper, is pretty compelling, because they only took severe aortic regurgitation patients. And all guidelines for decades agree that if you have severe aortic regurgitation with classic criteria, and you have symptoms, you need surgery. So they looked at these ones, which needed surgery. And they observed that if you're over 60, you have smaller ventricles and smaller end systolic volume. So practically, you don't dilate as much. So they were needing. So that it's very easy to extrapolate and say that it means that it's lower thresholds for volumes of the left ventricle we need, even in the ones that don't have symptoms.
So, no doubt that we are going to have and treat more and more patients percutaneously with aortic regurgitation. Becky, what are the top 5 ideal characteristics of a prosthesis, of a percutaneous prosthesis for treating aortic regurgitation?
Well, I think particularly we've learned from the ones that we have, or the one we have now, that has presented its data. But we believe that the commercial, obviously no regurgitation, right? So we want to eliminate all regurgitation, and so the skirts end up being extraordinarily important, the length of that skirt, etc., in order to help with that. The commercial alignment that occurs with the trilogy valve, I think it may have an advantage as far as just flow characteristics and helping those sick ventricles obviously recover by optimizing the amount of stroke volume. And what we've seen in the correlate for that valve is mean gradients as low as 1 and 2 millimeters of hernia, extremely good. With valve areas as large as 3 centimeters squared, we don't have calcium on the leaflets. And so now they're optimally opening, and they're very, very large for any given annular size. And so we want to optimize flow for sure. And then obviously we want to have those design that is going to allow us to redo TAV and TAV. So either easy to take out surgically if you've decided to do a surgical explant, or be able to put in another valve. And in addition, easy access to coronaries. Now, when you're grabbing leaflets, like the trilogy does, you don't have a coronary obstruction issue, because the leaflet has actually just been pulled away in the sinuses, and so that's a beautiful thing. And then finally, we want to make sure, I think, that the valve does what we hope it will do, which is help in remodeling. So hopefully that'll come with longer-term follow-up.
And then Patricio, you are super expert in imaging. So what are the top 5 things that we should never forget before sending a patient with aortic regurgitation for percutaneous treatment?
For percutaneous treatment, it's a bit different. You have to have an idea. The first thing for percutaneous treatment, the valve should stay in place. Huh? That's the first thing to do. So the selection of the type of valves is very important. So you have to describe all the anatomy of the aortic valve, annulus, the leaflet, so the presence of calcifications, the extension. If it is a pure AR without any calcifications, this is also something very important to mention. If there is symmetry of the sinus. If also there is enough size, to deploy the prosthesis, you need to have enough sinus because the valve should stay somewhere. And even if you don't have the issue of the leaflet obstructing the coronary artery, also the level of distance coronotomy is important to take into account. So I think, first of all, before referring, you need to confirm that it is a severe disease, so severe regurg, that you don't have so much left ventricular dilatations, at least to understand if you have to refer for surgery or for TAVI. And you need to describe the anatomy and to anticipate any kind of complications that you can get during the intervention. That's what you need. Even with imaging data, that's important.
And is echo, CT, both, MR?
I think when you are talking just about AR, echo, it's important and it is the first step, but you need to understand also what is the total connection with arteries, etc., and you need CT for sure. CMR is more for having an idea if there is some repercussion on the myocardium, so myocardial disease accompanying AR, or maybe to quantitate AR, but not necessarily to plan the intervention.
I have an anonymous complaint. Nobody's talking about functional component related to high blood pressure.
What I believe that obviously you need to treat the systemic hypertension. However, if you do have systemic hypertension, you will have more AR. It still means that you need to treat AR. It doesn't mean that you have too much to wait to see whether AR becomes better. I never perceive a significant improvement with just treating. Probably it takes longer. It may take several years and several decades. Where I perceive a fast difference is when I have less bradycardia. But with blood pressure, it's very, very small difference in the clinical setting, in the valve clinic. It's more significant in the cath lab when I do a TOE. As I said, if I increase peripheral resistances forcefully with metaraminol, then you see significant difference in AR. Just with the natural systemic blood pressure differences is very difficult, probably because it needs to be diastolic blood pressure to go up rather than systolic, so it's very difficult to see difference.
Clear.
I
Thank you.
was going to ask the panel, and since we have Patricio here as well, stress echo was mentioned on one of the slides, but we didn't really talk about it. And when you look at the beautiful article written by Patricio, what metrics do we use on stress echo to judge aortic regurgitation? I think that is less well defined than for mitral regurgitation and aortic stenosis. But interested in your thoughts.
Yeah, that's a very tough question because most of the studies, and there are very few, they've been done with dobutamine stress echo, not with exercise echo. The one on exercise echo, of course, you cannot quantitate the severity of AR. You have to just have an idea of the repercussion of AR on the left ventricle, but also on the diastolic function. Don't forget the diastolic reserve during exercise echo. We used to measure, the E over E prime to have an idea of the peak systolic velocity using tissue Doppler imaging at the level of the mitral annulus. And all this could be indices of the ventricular reserve in terms of recovery, in terms of function recovery after intervention. I've seen many beautiful images of LV dysfunction after intervention, but maybe this patient has no reserve at all. So if you wait too much, too long, without any reserve, and you intervene, maybe there it's better TAVR or TAVI than aortic valve replacement to avoid ischemic reperfusion and whatever it is. So that's the combination. I think exercise echo, for instance, in the patients from burnout, Prendergast, could be a very good idea.
If I might, if I'm sitting here between you guys and I have the chance to ask you a question, if I might ask, and we have talked a lot about thresholds and also quantification of CVAR, I think we have another problem with AR patients. I mean, even if we know, or even if you have quantified that they have severe AR, a whole lot of patients are undertreated or are not even referred to have surgery or a transcatheter option. What are your opinions on that? I mean, it's only, I think, 25% or roughly that are even referred, even if they have severe AR, and we've seen how much they, or how poor their outcome is. What are your thoughts on that, or how could we maybe improve that?
I think there the main issue is really the quantitation of AR, because they are misleading in the quantification. That's the reason also they are not referred for any kind of intervention. So there you need to use, and we have listened to many people saying multi-parametric, multi-modality imaging. You have to put all this, because if not, you will miss the real severity of AR. That's for sure. And after that, there is always it's a sort of philosophy. I remember the first paper from Bob Bono, it was in the 90s, saying that, okay, AR is a benign disease. Wait for dilatation before intervening. We put cutoff of left ventricular and diastolic volume to 70 millimeter before intervening. I think this time is finished.
Yeah, but what really has changed is that the patients, they don't want to go to surgery. This is clear. And this is why this also changed with we need to learn from aortic stenosis. We intervene more patients than we did. So I think that here we have new options, new treatment. This is why we need to better select. And let me, because there are many questions still related with the blood pressure. So how much does it interfere with aortic regurgitation evaluation itself? So do we need to control blood pressure before? Do we need to do serial evaluations? Or?
So, my opinion, as I said before, is that we don't, because it's not underestimating it. It might be overestimating it a bit, but I've perceived that as an advantage, because I will know the truth. You know, if you forcefully control the blood pressure to have a very low blood pressure at the time of your assessment, and you're underestimating what the aortic regurgitation of this patient usually is when his blood pressure is. So I don't believe that it's the same like aortic stenosis, it's the opposite.
But just an idea, perhaps it's a good endpoint for randomized trials on renal innervation.
And regarding why the fact, your question that actually very few patients are referred, I think that we need to do the same like recently is done with tricuspid regurgitation. We need to create a focus group, and we need to develop these focus group meetings in which to attract patients to be referred, because there is less frequency, less prevalence of aortic regurgitation in valve clinics, and people, even the ones that run valve clinics, may be less experienced, so send them to an expert to make a diagnosis when you think that the patient has symptoms but you don't think it's severe AR, but the ventricle tells you it's severe AR but it doesn't measure a severe AR. Ask a friend.
Maybe just one comment with systemic hypertension. Always you need to interpret this according to the fact that is it related to the AR, because the systolic pressure increased because the volume increased into the aorta, of course, or is it related to peripheral vascular resistance and compliance decreasing with age? And these are two different aspects. Because if it is related to age, of course, if you treat the systemic hypertension, this will have a huge impact, not only, of course, in outcome, on the evaluation, because you will increase, for instance, how you can detect the severity of AR if you measure the pulse wave Doppler velocity at the level of the descending aorta. It will improve the detection of the severity. So meaning that it's totally different interpretation.
Okay, so it's a 1:45. Can you finish? Or yeah, let us take last question from the audience.
Thank you very much for all of you. It was really very interesting morning. And I have a lot of comments, but I will just make 2 points, and I want at least to make a comment on that. So we were talking about quantification. We were talking about how how to judge the ventricle, what is ventricle telling us. But I think what we should as well add is what this particular lesion, whatever we grade it as a moderate or severe, means to that particular ventricle. So we have to match this. And then I think we will not go in the trunk to see the cutoff values. Is it 1.0 or is it 1.1? And just stick in that, not see the whole picture. And this is very important. How we can do this? I think it's a lot of studying and understanding what is going on in this ventricle. So for that reason, what we as well have to know, hemodynamic consequences of that particular lesion. So how the ventricle is coping with this lesion, and of course, what we don't know and we will desperately need is should we and when and how we should assess, is there any reversible potential in that ventricle. So we are very much talking about ejection fraction, but I think we forget what is the basic estimation of the ejection fraction. So for that reason, why we are using the same cutoff value for the aortic stenosis and aortic regurg. So 50% of ejection fraction means completely different in a ventricle that is after with coping with increased afterload and the ventricle with aortic regurg. In that sense, just if we see in any regurgital lesions that ejection fraction is below normal, meaning below 60%, the ventricle is not coping well with the lesion. I mean, it's sick, something is going on. The opposite is in aortic stenosis, because in aortic stenosis, even it is less than 50%, there might be reversible because there is an afterload that decrease parameter of ejection fraction, meaning nothing what is going to be after we treat the patient. So just your comments on that.
Any comment before closing?
The entire session, the entire episode 1. So, for aortic stenosis and aortic regurgitation, we totally agree with you. I think that we cannot put only the valve, we need to take it in combination with what surrounds, which is as well the left ventricle and other chambers. But I think that this was a perfect summary. Thank you.
Yeah, no, I think we need to close. Thank to the speakers here that we don't treat valves, we treat patients, but we have new hope now for treating in a different way and much more modern aortic regurgitation. Thank you, and we have lunch in 2 o'clock.